Good afternoon, everyone, and welcome to the Cancer Research and Screening session. As we know, cancer remains one of the most pressing health challenges here in the Bahamas, impacting the lives of Bahamians every year. Today, we'll highlight groundbreaking work that advances our understanding of cancer biology, improves early detection, and enhances patient outcomes through innovative screening approaches. Our presenters are leaders and rising experts whose work will drive meaningful change across research, clinical practice, and population health. Now, to begin this session, we are honored to start with our keynote speaker, Dr. Ian Jackson. Um, Dr. Jackson will talk through the development of the Sir Clive Lloyd Healthcare Foundation, of which he is the new CEO. Dr. Jackson is the national advisor for the opt-out testing implementation in the NHS in England, which is implementing routine testing for HIV, hepatitis B, and hepatitis C in 90 emergency departments across England. He is also the contracts and planning director for the London Specialized Commissioning Directorate at NHS England, which is responsible for a budget of about 60 billion pounds. In addition, he is a trustee of the Rethink Mental Illness, the largest charity in England, working with people living with or affected by serious mental illnesses. Dr. Jackson is married to Diane and lives in England. He is a huge cricket fan and is a very keen golfer. Let's welcome him today.
Dr. Stubbs, thank you very much for the welcome. I'm just checking you can see and hear me okay in wet, windy, cold London, which is where I am. I want to thank everyone for the invitation to speak. And the first thing to say is, because I know I'm at an academic conference, this is very important. I'm not a doctor, so I don't know. I'm just Ian, but I work with a lot of doctors. But I just wanted to make sure that was okay to say. So I will attempt to share my screen, hoping this is going to work. I'm always nervous when I do this, but I'll do what I can. So I'm hoping you to Clive. Is that okay? Can you see the screen?
Yes.
Thank you. So Clive Lloyd, he may need no introduction, but I was introduced to him in February this year through some of the work I do with a doctor called Dr. Moti Rangapal, who is based in Florida but is from Guyana. And I've been doing some work in the HIV space. And he said to me, "Hey, and what do you know about prostate cancer?" And I said, "Well, not a lot, but I know a lot about testing." And when I say I know a lot about testing, this is the program that I run for NHS England, um, which is active in emergency departments. So if you come into an emergency department in any of there are currently 82 live sites around England, and you have a blood test for any reason, we have a big sign up and we say, we're going to test you for bloodborne viruses. So we're going to test you for HIV, hepatitis B, and hepatitis C. So we'll take another vial of blood. That's in very, very busy emergency departments, and it's a relatively small change in process, but it's been incredibly effective. So these are the latest published numbers that we've put forward. We've done 10.5 million tests. We've done more than this now. We've 10,500 carrying a virus. Most of the people who were there, and we found and were previously diagnosed and were receiving those are just So we obviously know that the process is working for people who are newly diagnosed, but actually it's also picking up people and confirming that they're receiving treatment already. Now, this is an interesting program because it's been really well received by the whole of the NHS in quite an unusual way. In some respects, and the emergency departments are really the kind of epicenter of everything um, that is busy. So actually approaching them and saying, "Hi, we want to change your process," was an interesting thing to do. But where we got to was they said to the emergency department clinicians when I went to see them said to me, "Well, if you tell us what happens to our patients, we'll do it because no one ever tells us really what happens. We know if we admit them or we discharge them, but we're not quite sure. We're not quite sure after that." And people get a real sense of gratification about this opportunistic testing and picking people up and being able to really help them. I will. I'll try and move on. Sorry. So moving that prostate cancer meetings apply. The situation is we've got the Caribbean having this silent crisis and this mass epidemic of prostate cancer in men, leading cause of death amongst men in the Caribbean. Uh, Highest global rates, pretty much of anywhere that records the data. You can see the Bahamas is third in this table. You look at the global rates of at the bottom there of world prostate cancer mortality and morbidity, and the Caribbean is obviously incredibly high. So we have insufficient testing is the feedback that I've been working on, and I've been out just once so far, but I've been learning as I go and working with the urologist, leading to cancer being detected later and in a more deadly stage. And then that's further complicated by systemic barriers, not just disease. So we've got stigma discouraging early testing, people being worried about where someone might put a finger or not, um, limited access to modern diagnostics and surgical options, inadequate support for mental health and survivorship. And this is a really key one for me. The Caribbean is massively underrepresented in global prostate cancer research. We know that, most global research is still happening to white men. Uh, women for this case. So we want to really
It appears as if we're having some difficulty with the connection. So give us a minute.
I think I'm back, but I'm not sure.
Okay. All right. Yes, you are, sir. I can hear you. Hello?
Hello, can
Okay.
you hear me?
Yeah, the connection is pretty bad.
I'm sorry, that's London for you. We're on old technology. I'll try and get it working a bit better. I'm in a very.
Sure.
Uh,
Okay.
I'll try and share again. I'll give it one more go.
Okay.
I don't know where you got to before I fell off the line, but I'm hoping that we can.
It's difficult to hear. Yeah, I can't hear you at all, to be honest.
because that might help as well. So, um, okay, so I don't
Hi, Dr.
know.
Mr. Jackson. We will share your slides.
Dr. Halliday, should we start the presentations and see if we could get back to his presentation later?
Should be
Okay,
fine.
so he's saying that he would try to come back later. So I think we should just get moving to the presentations, okay?
Okay.
Now we will start our presentation to begin our first research topic. We could start that now until Dr. Jackson is ready for us. So our first research topic is a real world analysis examining the impact of GLP-1 receptor agonists on all-cause mortality and GnRH therapy tolerability in obese prostate cancer patients. Okay. So this presentation will be done by Dr. Colton Jones. Sorry, Dr. Jones, I hope you're ready. Are you on? Is Dr. Jones on? Okay, just give us a minute.
Oops. We can move on to Ron Elias.
Okay, Dr. Ron, so it looks like you will be the one to help us. Okay, today.
All right. Ron to
Good
the
start.
rescue, I guess.
Yes,
Can you
please,
hear me?
rescue. Yes, we can hear you.
All right. Sorry about this. This is obviously not a cancer topic, but heart failure is a very malignant type of disease. So I think there are a lot of similarities. Probably heart disease and cancer go hand in hand, unfortunately, and affect a lot of our patients, probably the vast majority of our patients. I'm going to present a case of a patient, a young patient that I did at a different hospital I worked in, under the hat of interventional cardiology. I'm going to turn my video off so we don't have any interferences, and I'll share my screen right now. Yeah, so this is a case from a few years ago, and it sticks out as a very case and point and a very important learning case, and I think we can all deduce a lot of significant valuable points from this. So this is a 29-year-old patient, female patient with a diagnosis of Marfan syndrome, and she had all the interesting features of this genetic condition, part of which involved the heart and the great vessel, the aorta. She had an aortic root dilation that was very significant, reached up to almost to 5 centimeters, with considerable leakage of her aortic valve. And for that, she underwent replacement of her aortic root and ascending aorta with valve preservation and coronary reimplantation. That was done 3 years before presenting to us. Another common feature which she had was an orthopedic, more of a condition called pectus excavatum. Her chest wall was deformed, and she had to, for the aortic surgery to take place, she had to go through a kind of a reconstructive surgery to even allow us access to the aorta. So this is only in the background, and she actually came in with signs and symptoms of heart failure. She was having progressive shortness of breath, a New York Heart Association classification of almost 4. She couldn't go to the washroom without having significant shortness of breath, pre-syncope and low blood pressure, and essentially presented cardiogenic shock. Her first echo, the transthoracic echo, showed dilation of her left ventricle, but more significantly, severe leakage of her aortic valve. And at this point, we have also noticed that she's in multi-organ failure. Her kidneys were shutting down, liver enzymes were up, and she was essentially in full-blown cardiogenic shock. So things had to move quite fast with this young patient. This is her TE. I picked one slide, one video, a loop of the TE, and what you can see basically is all this mixture of turbulent flow, the blue and yellow appearing on our screen, and all this blood is flowing back into the left ventricle, and that's what you see, and that's what you don't want to see when the aortic valve completely fails, basically. So this is severe aortic regurgitation. This is how it looks on an echo. And I hope none of you have to see this. Again, these are very hard pictures. A CT scan was done to assess her anatomy, and of course, it's a very important step in planning a procedure like this. Of course, we took reconstructive images of her aorta and her chest wall. You can see how deformed it is on the lower left-sided corner. The heart is essentially pushed into the left side of the chest, and the sternum, the sternal bone, is leaning against, in this case, it's the pulmonary artery, but the aorta is compressed by it as well. Now, these features of the anatomy are very important, because when you ask a heart surgeon, what's the most thing you fear of, is, well, when I saw the chest bone, I don't want to hit any large or major arteries on the way. Major artery being the aorta, or the pulmonary artery in this case. You can see it's essentially stuck to it. So if we're planning on doing a surgical intervention on a patient, replacing her valve, this is pretty much prohibitive to a direct approach. So that's one thing. There are other approaches that we can access the aorta, but in this case, it was extremely complicated. Remind you that the patient is in shock as well. Of course, at this point, when we had the images, both the echo and the CT images, we had to have a heart team, which is a very healthy working habit in all major hospitals today when we encounter very, very sick patients, but even not very sick patients, also patients who have very common illnesses like aortic stenosis. We do heart team meetings, and we bring up all the the harsh questions and plan what are the steps to be taken next. So what we're encountering is, or what the mission was basically, is what the decision was, is that the patient is prohibited for surgery. The patient's only option is basically putting in a new valve. Fortunately enough, we had the technology back then, which is called TAVR, and today it's a very common procedure done a lot of patients with aortic valve disease. So the plan was to do a TAVR, transaortic valve replacement, in her ascending aortic prosthesis because she has acute aortic regurgitation and she's in shock. This is our starting point. Her blood pressure was 80/20. Her pulse was 130, probably even more. She was on pressors. We had to put in a pacemaker to allow us to complete this procedure and to support her pulse that went down during the beginning of induction. We chose a 34 millimeter core valve, which is a type of prosthesis that we use in very, very big types of aortas. We started out the procedure. These are coronary angiogram images of the procedure. You can see dye injection into the left coronary artery. That ring type of structure you see there, that's the mitral valve repair she had. I didn't mention that, but she had mitral valve repair during her first surgery. Left coronary injection. This is a right coronary artery injection. You can see that the coronaries are normal. This is what we call a pigtail injection. It's placed right in the aortic root, and that gives us a sense of the landmark we need to be using to implant this valve. The problem with patients with aortic regurgitation, as opposed to aortic stenosis, is that they don't really have calcium that we can hook our valve onto and secure it in place. And that's what makes it very challenging, because the valve might dislodge, might move with the flow of blood. You can also appreciate the severe AR. This is the device. This is how it looks. It's a core valve, and we have the ability to position it and then maneuver it as needed. We can push it down, we can pull it up, and we can slowly deploy the valve as we move. And this is done to prevent, valve from popping, valve from springing. You can see it's a stented type of valve. You can see the meshwork, and inside of it, there's a prosthetic made of some forms of biological tissue. And this is how it's crimped into that device, and we unfold it or deploy it in position once we're happy with our landmark. So this is from the procedure. You can see this is done under rapid pacing. The heart is barely moving, and that's to allow the valve to be in position. We also measured continuous pressure. So this is the first attempt in positioning. You can see that the valve is 90% deployed. You can see that there's injection showing the coronary arteries here, and the valve looks kind of secure in position. You can appreciate the heart rate is very, very low and slow at this point. And I can tell you from her first hand, being under this condition, we were pretty much clenching our teeth and fearing for a patient's life right now. This is another reposition of the valve. We weren't very happy. And now you can see the valve release. That means that the position, after making sure under imaging that we were satisfied, we dishooked the valve. We essentially detached the valve from the device, and the valve is now functioning and in place. You can see it's not moving. This is an injection after taking all the hardware out and the valve in place. We do a pigtail injection again to see that the coronaries are filling with blood. And you can see that the valve is competent in terms that there's no dye leaking back inside. Well, a little bit, but not a significant amount of dye leaking back inside the left ventricle. That means that the valve is competent and it's doing what it's designed to do. Now, after we deployed the valve, we had an immediate blood pressure recovery. Patient, even we turned the pacemaker off, and the patient even regained her sinus rhythm. She was advancing so good that we could put her off the inotropes she was on. She was extubated few hours later, and we took out the pacemaker. This is another transesophageal echo showing the valve. You can see very nicely the struts, the metally appearance, the valve in place. And this is with color. You can see that, or trust me on this, there's no leak inside the ventricle, or no back leakage of blood into the ventricle. To conclude, this is about a year and a half after the procedure. This is a picture of her holding her baby. So, and this always is an emotional aspect of what we do, of our job, and for me personally, because not only being able to save a life with technology and with wonderful people on our side, but this is just you can see that, you know, we're not just saving lives, we're also saving lineage. We're also allowing people to fulfill their meaning, their true meaning of life. I think the take-home messages from this case, and we can probably I can probably recycle this slide and many other slides. It's teamwork. There's no I in teamwork. This is pure teamwork. You know, I think put our egos aside. We had surgeons on our side. They, you know, no room for other, you know, harsh, and we didn't have really time for any elaborate meetings, and because the patient was definitely, she ran out of time essentially. Communication is key, and this is with everything we do. And of course, thinking outside the box. And this is something I think doctors and healthcare professionals and even paramedical people who deal with healthcare, especially here, we are good thinkers outside the box, and we are very creative when needed. So this just shows the really essence and the cutting edge, and really what the peak of that pyramid with a strong base is really capable of doing. And with this, I will conclude.
Okay, thank you so much, Dr. Ran. Right now, we will welcome any questions that the audience may have for you. It was a very interesting presentation. Very interesting. Topic is complex, but thank
Yes.
you.
It is probably one of the extremes in what we encounter on our daily basis. But ever since I started working here, I work for Doctors Hospital. Ever since I started working here, I've seen a few cases that could very much have ended in the same way. And it's with that collaboration and that teamwork that pull these young patients back into safety. So I think the system here is very, very good in that sense, and I feel very confident with my patients needing that urgent attention.
Okay, and thank you so much for all the work that you do.
Thank you.
Okay, so I don't see any questions. All right. Thank you for rescuing us. Okay.
My pleasure. That's what we do.
All right. So I didn't have a chance, well, I actually didn't introduce myself. My name is Dr. Stubbs. I'm internal medicine consultant at the Rand Memorial Hospital. Okay, so I'll be a moderator for this session. I see that Dr. Jackson is back, so we'll try to have him do his presentation now. Okay, Dr. Jackson, you ready?
Thank you. I think so. Can you hear me better now?
Yes, we can. Thank you.
Oh, excellent. Thank you. I'm so sorry. I'm incredibly embarrassed.
Okay.
I can't get any tech working. Let's see if I can share my screen again. And I'll do a very brief run through of the first couple of slides, which I think I'm hoping you can now see.
Yes,
this is the Sir Clive Lloyd Foundation of the Great Catch. Thank you to Dr. Elias as well for covering that. The foundation is based on learning from different screening techniques. So we run, or I'm part of a very small team that runs the England Bloodborne Virus Detection Programme for HIV, hepatitis B, and hepatitis C. And this is a mass screening project for which has conducted over 10.5 million tests now in England, and has found 10,500 people who didn't know they were sick. So these are people who go into an emergency room, have a blood test for any reason, and we take a second vial of blood and we test it for those 3 viruses. Now, the overwhelming majority of cases are negative, but actually the cost to the system of not finding and treating early for the new diagnosis is very substantial. And what we've got here is a number of cases who were previously diagnosed and not in care, and previously diagnosed who are in care. So it's kind of reassuring that it's picking up people whether they've been previously diagnosed or not. In terms of where we are in the Caribbean, we have prostate cancer as the leading cause of death amongst Caribbean men. We have one of the highest prostate cancer mortality rates globally. You can see the Bahamas there on the 3rd line down against the global stats at the bottom, and that's from Cancer Today, the IARC publication in 2022. And mortality and morbidity rates are hugely higher in the Caribbean, and in the Bahamas there is 3rd on the list. And this, we think, is because of insufficient testing, leading to cancer being detected later and at a more deadly stage. And to complicate it, there are systemic barriers. So it's not just the disease. So there's a lot of stigma around discouraging early testing, people being very afraid of having a finger inserted into them, generally, let's just call it what it is. There's limited access necessarily to modern diagnostics and surgical options, and inadequate support for mental health and survivorship. And the Caribbean is hugely underrepresented in prostate cancer research globally. So in the studies in the UK, the Caribbean is not front and centre where it should be, given the effects it has on men in the region. So there's a question about, can we lead the fight? So this is Dr. Paul Rouse, who's a urologist in Barbados, with Sir Clive in his clinic. And what we're looking to do is see if we can catch prostate cancer early, see if we can treat it better, and see if we can lead global research from the Caribbean itself. And our answer is this program, The Great Catch. So it's a game-changing program for men in the Caribbean, led by Sir Clive. It's a structured 3-part program to reduce prostate cancer mortality, which will look at global research leadership, community engagement and stigma reduction, and advanced testing and treatment. And what we mean by that, and these are all pictures of Clive from his career that we've put in there. And I don't know how many cricket fans there are in the room. I know it's not the necessarily the biggest sport in the Bahamas, but I'm hoping that there's enough fans in the room. The Global Research Hub, so build research infrastructure in Caribbean institutions, particularly with the University of West Indies, and we have done some partnering already with you, and I'll come back to that. Collaborate with global cancer research centres, and we have a lot of those in the UK, so they are available, and collect and analyse region-specific data. The second pillar is community engagement, and this in some ways is dealing with the mental health and stigma of male communities, and dealing with prostate cancer, the effects of treatment, the after effects of treatment, the effects of not having treatment at all. And this isn't just for men, this is for anyone who's affected by the prostate cancer that affects those men. But training local ambassadors for prostate health education, and also to run culturally sensitive awareness campaigns. And then the third pillar is advanced testing and treatment. So this is where we get into mass testing drives. And I know that, as I've spoken to Dr. Robin Roberts about this, and I know there's been drives in Grand Bahama before, but mass testing, and then getting onto, well, you can't really do loads of testing if you haven't got available treatment options. So you only do testing when you can match that to the treatment available. So you don't want to test absolutely everyone if you haven't got system capacity. My role as a commissioner in London is to build the capacity in the systems at the same time and then apply the testing to it. But realistically, we're pretty well off for the treatment capacity once we've done the testing. And then we use high precision MRI and transperineal biopsies, ideally, as the latest technology to do the better identification. And then expand access to advanced and minimally invasive surgery where we can. And then build those clinical pathways in a co-design fashion. So actually, this is all the experts in the locality telling us what would help, and us then trying to raise funds for those different interventions. But ultimately, it's to build care pathways for early detection. And then why are we doing this? Well, partly we're doing it because Sir Clive really wanted to, and he didn't need to do this. He has a legacy already. He's, I don't think he'll mind, I think it's a matter of public record. He's in his 80s now, but he sees this as a tipping point for Caribbean health equity. He's lost an awful lot of friends, and wants to stop losing people, and the impact it's having on families in the Caribbean is a massive issue for him. He has a lot of trust, and he has, clearly significant leadership qualities that he's going to bring to it. We have some immediate impact projects ready to go. We have strong community sports and policy networks, and we think that the Caribbean, instead of holding that position where obviously it's terribly badly affected, can start leading the world in prostate health in all of these different aspects. And then, what we need from various different people, obviously, in order to do this well, we need funding in different territories, but there's different ways to do that. We can have small testing drives. We can have NGO partners. University of West Indies has already been an incredibly helpful partner, working through the Cave Hill campus in Barbados in terms of the work it's doing on acceptability of different interventions. And then the impact is going to be transparent and measurable outcomes. Now, this is a bit of a spoiler because we're going to the CURA conference, the Caribbean Urological Association conference, in a couple of weeks in Jamaica. And what we're going to talk about is this particular project, which is being led by the Institute of Cancer Research. It's called PRACTICAL, the Prostate Cancer Association Group to Investigate Cancer-Associated Alterations in the Genome. I think they took a while to come up with that acronym, but they managed. And that's led by Professor Ros Eales here at the Institute of Cancer Research, which is based at the Royal Marsden Hospital in London. And the idea is to combine many studies globally to provide a reliable assessment of risks associated with prostate cancer and genetic variants, to assess gene and environmental factors, and to assess the clinical application of those things. Now, this group, PRACTICAL, has 116 active study groups worldwide, 50 in Europe, 50 in North America, 6 in Asia, a couple in South America, a few in Australia and some in Africa, but hasn't got any current active sites in the Caribbean. So although there are a couple of dots in the map there in the Caribbean, they're not active in terms of providing sample data. And this is the amount of samples they've collected over time. And these are just the venues they have their meetings in each year. And it'd be great, I think, if they could have one in the Caribbean at some point, if we can get some sites signed up. And what we're trying to do is expand that study into Caribbean countries, maybe with some match funding. And when we're talking about the funding required for these studies, I'd be interested in the view of the room, but we think it would cost approximately $20,000 to get a country signed up in full on this program and collecting the biomarker data that is really sorely needed to look at why prevalence is so high. We will help to fund that research. And that's going to be our first program that we do. So we want partnerships for the countries. We'll get ethical approval, which is already in motion from the University of West Indies in Cave Hill. And appointed principal investigators will get invitations to annual consortium meetings. The next one is in Granada in Spain. But also that you will also be an author, if you're the principal investigator, on any study that this group ever publishes in the future. So I think there's really something in it. The quid pro quo from the Great Catch and from the partnership that we're now working on is that what we want when you sign up to this is actually a plan for how you think you can make it better. What are the projects in your country that you can make better in partnership with urologists, but also with the ministries and also with the academic institutions and also with CARPHA, the Caribbean Public Health Association, who we're also working with. So that's, we think, a good first step into making this a real proper collaborative partnership. So in closing, we think the Great Catch is a game changer. We think we could have significant impacts as long as people want to get involved, they can get involved. We'll work with the countries that want to work with us. We're not precious about who that is, as long as they want to do something with us to raise the profile and to try and raise some money into prostate cancer. And we think, and this is a quote from Sir Clive, which is that he's prepared to do what he can to help, and he's asking you what you're prepared to do. And I want to say thank you. Hopefully you can join us in the future. And then this is just a one-page summary of what we're trying to do and everything I've just covered, which we'll obviously make available to you after this. But thank you. I'll stop sharing there.
Thank you so much, Doc, for your very informative presentation. We thank you for the work that you are doing. We'll see if we have any questions from the audience for Dr. Jackson. Okay, and if we don't, then we will move on to our cancer research topics. Okay.
Can I ask you a question, Dr. Stubbs?
Sure.
Okay.
Yes, that's
So,
correct.
so because obviously you're the first group that I've presented this to. So is the coherence of an offer like let's sign up to practical something that you think that would be of interest in the Bahamas or in the wider Caribbean?
Yes, it would. Yes.
Okay, that's good. That's good to know.
Yes, very much so.
Great.
Yeah, thank you so much for the work that you are doing. Thank you.
That's a pleasure, and thank you very much for the invitation. I'm really sorry about the technical difficulties we
That's
had earlier.
fine. We understand. Thank you.
Thank you.
Okay. So, our first cancer research and screening session presenter would be Dr. Colton Jones. Dr. Jones is a native of San Salvador and is the first medical doctor from that island. He graduated as the valedictorian of the University of the West Indies of Clinical Medicine and Research at Bahamas campus in 2019. He earned a coveted internal medicine residency at Jefferson Einstein Hospital in 2022 and was inducted into the San Salvador Island Hall of Fame that same year. He completed his IM internal medicine residency and is now a consultant in internal medicine. He was accepted to a prestigious hematology and oncology fellowship at the University of Texas San Antonio May Center, Cancer Center, MD Anderson. He has co-authored and presented over 40 cancer publications at some of the world's most prestigious cancer conferences, including the American Society of Hematology, the American Society of Clinical Oncology, SABCS. His research focuses on the role of metabolic health in breast, gastrointestinal, intestinal, and urological cancers. He is dedicated towards revolutionizing cancer care in the Bahamas through clinical trials and research while providing compassionate, patient-centered care. Now, Dr. Colton Jones's topic will be the impact of GLP-1 receptor agonists on all-cause mortality and GnRH therapy tolerability in obese prostate cancer patients. I'm sure this will be a very interesting presentation that should highlight an important link between obesity, endocrine therapy, and cancer outcomes. Let's welcome Dr. Colton Jones.
Thank you, Dr. Stubbs, for that introduction. Can everybody hear me okay?
We can.
Yes.
All right, without further ado, I'll get started. I must say I'm extremely excited to present to my first research day, and I'm excited to share our results from our retrospective study entitled A Real-World Analysis on the Impact of GLP-1 Receptor Agonists on All-Cause Mortality and GnRH Therapy Tolerability in Obese Prostate Cancer Patients. I want to say a special thank you to my co-authors, Dr. Gabrielle McKinney, Dr. Chelsea Brown, as well as Dr. Ellis Obumanu for their support and contributions towards this research. And we have no financial disclosures. So obesity worsens prostate cancer outcomes, and particularly during gonadotropin-releasing hormone therapy. And this is due to a lot of factors. It can be due to metabolic dysfunction. It can be due to decreased treatment tolerability, as well as elevated cardiovascular risk. Now, emergent evidence suggests that GLP-1 RAs may offer oncological benefit that is beyond weight control and beyond glycemic control. There are a lot of in vitro studies that have been done, many of which have shown that xanadin-4, which is a GLP-1 receptor agonist, inhibits tumor proliferation in prostate cancer cell lines through several key molecular pathways. Figure 1 highlights one of those key molecular pathways involving the 8-KT-mTOR pathway, which is a key pathway involved in cancer survival, migration, as well as angiogenesis. And so we hypothesize that GLP-1 RAs may offer a survival benefit that is beyond their obesity or glycemic controlled links. And so this study is actually the first study of its kind to evaluate the real world impact of GLP-1 RAs on all-cause mortality and GnRH therapy tolerability, particularly in obese prostate cancer patients. Now, in regards to our methodology, we utilized a large database, TriNetX, which is a database that encompasses over 130 million patients, and they utilize de-identified patient data, and so IRB approval is not needed. We identified obese prostate cancer patients with BMIs greater than 30 who were receiving GnRH therapy. Patients were stratified into two cohorts: the treatment group, cohort A, those receiving GLP-1 RA, and cohort B, those not receiving GLP-1 RA. Now, our primary endpoint was all-cause mortality, and this is because data has shown that patients with prostate cancer are at higher risk of dying from other causes unrelated to their malignancy. Our secondary endpoint was GnRH therapy tolerability, whether or not GLP-1 RAs worsened or improved side effects from GnRH therapy. We also performed subgroup analyses. We looked at age, we looked at BMI severity, we looked at the presence or absence of diabetes, underlying cardiovascular disease, as well as type of GLP-1 RA agent. We utilized propensity score matching, which matched patients in a 1-to-1 ratio based on the nearest neighbor algorithm. And this was particularly based on underlying demographics, comorbidities, stage of cancer, as well as if patients received prior treatment for their malignancy. Results are expressed using hazard ratios and odds ratios with 95% confidence interval. And this was via multivariate logistic regression. Figure 2 highlights our study selection process. We also excluded patients who were on metformin or other oral hypoglycemic agents just to account for additional confounders. Now these are our study results. Starting with demographics, we can see here, and the main highlighting point here is that after patients were matched, we see here that the age of index event was approximately 65 for both treatment and control groups. Whites made up the predominant race, followed by Blacks and then Asians, and 100% of our patient population were male. We also looked at several other characteristics in our study. We looked at whether or not a patient had prostate surgery, and about 14% of both treatment and control group underwent prostate surgery. The average PSA was about 32 for those on GLP-1 RA therapy versus 42 in the control group. Approximately 40% of patients in both treatment and control groups had a diagnosis of diabetes, with the average A1C being 7.3% in the treatment group versus 6.9% in the control group. And the average BMI was 35 for treatment group versus 33 for the control group. Now, I think one of the limitations of our study was that cancer stage was largely unreported in the database. And we can see here that only about 11% of patients had a cancer stage assigned, with stage 2 being the most reported cancer stage. So when looking at our primary endpoint, which was all-cause mortality, patients in the treatment group were followed up for 2,054 days versus 1,931 days for the control group. And looking here at this table, patients with outcomes of all-cause mortality, we can see that in the treatment group, 154 patients versus 247 patients in the control group experienced the outcome of all-cause mortality. And this yielded a hazard ratio of 0.588, favoring the treatment group. So the association that GLP-1 RAs have all-cause mortality benefit. If you see at the bottom of this slide, we have a Kaplan-Meier survival curve analysis. The purple line is the GLP-1 RA treatment group versus the green line is our control group. And we can see a clear separation of the lines that got even better as patients who are on GLP-1 RAs are much longer. And so these results suggest mortality benefit favoring GLP-1 RAs. Now, we also performed subgroup analyses, and our subgroup analyses also supported this survival benefit. Regardless of age, there was survival benefit, but the benefit was greater in age 18 to 69. This had an odd ratio of 0.532. Regarding BMI, the benefit was better for those with BMI over 40, had a hazard ratio of 0.474. There was mortality benefit whether or not a patient had diabetes, which was quite interesting. There was mortality benefit in patients with cardiovascular disease. And when we looked at specific GLP-1RAs, semaglutide along with dulaglutide showed significant mortality benefit, with no significant benefit reported for tirzepatide. We also looked at secondary endpoints. So we wanted to see if GnRH therapy side effects were worsened when patients took GLP-1RAs. And our results did report worsening of certain side effects. And the statistically significant results from this table were worsened erectile dysfunction, vasomotor symptoms like hot flashes, the risk of osteoporosis, as well as depression, risk of acute kidney injury, fatigue, and gynecomastia. These were all statistically significant results. There was no association between GLP-1RA and risk of venous thromboembolism or risk of Alzheimer's dementia. The p-value was statistically insignificant. And so I wanted to mention some of the strengths and weaknesses or limitations of our study. This study is quite novel, and to our knowledge, this is the first study to evaluate the impact of GLP-1RAs on all-cause mortality and GnRH therapy tolerability, specifically in obese prostate cancer patients. So it's quite novel. We also had quite a large sample size, so we were able to obtain statistically significant results, both for the primary endpoint and the secondary endpoint. Our study had several limitations. The first, being a retrospective observational study, one can only conclude association, but not causality, and therefore more prospective studies are needed to determine causality. With any large database that uses ICD-10 codes for diagnoses, there's also a risk of misclassification bias. And so that's another limitation of our study. And probably another significant one was missing data. Cancer stage was largely underreported, and it would have been interesting to see what the outcomes were for patients who had early stage disease versus metastatic disease. And so in conclusion, our study showed that GLP-1RA use in obese prostate cancer patients on GnRH therapy was associated with reduced all-cause mortality, but increased GnRH treatment-related side effects. These findings highlight a very complex therapeutic profile, and so further prospective evaluation is warranted. Thank you.
Thank you, Dr. Jones. Was a very interesting topic. Any questions from our audience for Dr. Jones? Thank you. I see Dr. Sinqui has a hand raised.
Thank you very much, Dr. Stubbs. Just wanted to mention, as someone who's just started his fellowship, I'm absolutely amazed at the amount of research that Dr. Jones has put through in such a short space of time during his residency. And now I'm looking forward to even greater things for him in fellowship. And in just speaking with him, I understand that his goal is to come back home. So I'm hopeful that he'll be able to inspire and motivate research culture when he comes back as well. Congratulations.
Thank you, Dr. Sinqui.
Okay, any more questions? All right. So Dr. Jones, we are very proud of you. Like I said, excellent presentation, excellent study. Continue to do well. Okay, thank you very much. So now we'll move on to our next presenter. Our next presenter is Dr. Delicia Bodie. She is a dedicated general surgeon and actually the first Bahamian female to complete the Doctor of Medicine in the general surgery program at the University of the West Indies. She is committed to elevating the quality of surgical care in the Bahamas. Dr. Bodie currently serves as a general surgeon at Doctors Hospital, providing consultation and performing general and oncologic surgical procedures using both traditional open and minimally invasive approaches. She also holds the role of senior registrar at the Princess Margaret Hospital, overseeing junior staff and contributing senior surgical expertise to the public health system. A strong advocate for continuing education and advanced techniques, Dr. Bodie is recognized as an associate fellow of the American College of Surgeons. She further honed her expertise by completing the MIS Master's course of Advanced Minimally Invasive and Robotic Techniques for Emergency General Surgery at the ACS clinical session. So Dr. Bodie's presentation will be on, are we screening too late? Clinical pathological findings of colorectal lesions at the time of colonoscopy in the public hospital system in the Bahamas. Okay, I'm sure that this study could raise a lot of critical questions about the timelessness of screening, disease staging and detection, and potential implications for national screening guidelines. So let's welcome Dr. Bodie.
Good afternoon and thank you. Just confirming that you cannot see my presenter view.
We can actually see it.
You're seeing the presenter view?
Yes. We're seeing your presentation.
No, we can see the slides properly. Yeah.
Okay, do you see the presenter view now?
No.
Okay, great. So good afternoon again, and thank you for the opportunity to speak at this year's research days. Just to get right into it, I have no disclosures, and I'd like to thank my co-investigators for contributing to this study. So screening is the process of testing for disease in a clinically asymptomatic but at-risk patient. And for colon cancer, we know there are various modalities of screening, including colonoscopy, our stool-based testing, flexible colonoscopy, and your CT colonoscopy. And of all, the colonoscopy still remains the gold standard as it has the highest sensitivity. This slide depicts the well-known sequence of events that happens in the adenoma to carcinoma sequence to colorectal cancer. And it shows the various lesions that can present during each step of the process. And it's important to note and be familiar with this sequence, as each lesion has its own risk and dictates in terms of the different timing for surveillance for patients, but depending on what their lesion is and treatment options available. The adenoma detection rate is an important thing for us to note. It is the proportion of screening colonoscopies performed by a physician that detects at least one histologically confirmed colorectal adenoma or carcinoma. And that rate for males should be more than or equal to 25%, and for females, 15% or more. And it's important to note that a 1% increase in an endoscopist's adenoma detection rate has a 3% decrease in the risk or likelihood of a person developing colorectal cancer in the following year. So it's very important for us to make sure that we achieve these specific adenoma detection rates in order to prevent colorectal cancer. So in 2002, Imperial et al. Investigated the importance of screening age for colonoscopy and noted in their study that there were no lesions identified on screening colonoscopies in patients aged 40 to 49 years. However, almost 20 years later, Sigel et al. Noted that among individuals aged younger than 50, the incidence rate increased by approximately 2% each year for tumors in the proximal, distal, and distal colon, as well as the rectum. As a result, in the following year, 2021, the U.S. Preventative Services Task Force released a statement to lower the age or include persons age 45 to 49 years so that we can adequately screen and capture this subset of population. When looking at international data, Zhang et al. From Japan performed a study and noted that precancerous lesions were actually the most common lesions identified histologically in patients who underwent Cologuard followed by colonoscopy screening. In contrast, Oluwatosin from Africa reported that colorectal cancer was actually the most common histologic findings in patients of the middle-age group. When we look at our regional data or in the Caribbean, Palmer et al. From Jamaica noted that normal colonoscopy findings were noted in their patients, about 30% of their patients, with 10% having cancers and a history of bleeding being the most important predictor of an abnormal colonoscopy. In Trinidad, Cowich et al. Reported more than 80% of patients had negative colonoscopies, and about 15% of those actually had neoplastic findings on biopsy. There was a local study done by Chandra et al. That reported that almost half of patients with colorectal cancer were diagnosed at the time of colonoscopy, and the average age of diagnosis was 65 years with a male to female ratio of 1.3 to 1, and patients under the age of 50 accounted for almost 20% of colorectal cancers. So given the published literature that we well know supports Bahamians developed, even looking at breast cancer at earlier age and more advanced stages than our American counterparts, we thought it was imperative to investigate the need for lowering screening age for the detection of colorectal cancer in the Bahamas. The aim was to determine the need to lower the screening age for colonoscopy in our country with the objectives of determining the adenoma detection rate, determining the distribution of colorectal lesions by age, sex, and anatomic locations, as well as looking at the pathologic distribution of these lesions at the time of colonoscopy. So following ethical approval, a retrospective review was performed over a 6-month period and included all colonoscopies performed within the public hospital system from January 2015 to December 2024. And patients who were identified as having an OGD, upper endoscopy, ERCP, or aborted colonoscopy procedures were excluded from this study. We obtained electronic colonoscopy reports using our Surgical Information System, or SIS, from the Princess Margaret and Rand Memorial Hospitals, and reviewed the histopathologic reports from SunQuest ICE. Looking at the results, we had just over 1,500 endoscopic procedures performed during that period, of which just over 1,521 were colonoscopies with exclusion of 15 OGDs, PEGs, 24 aborted procedures. There were actually almost 200 repeat procedures done. And so we had a tally of 1,497 colonoscopies for our COOD number. This slide shows the distribution of colonoscopies per year between the two hospitals, the Rand Memorial in Orange and Princess Margaret. And as expected, Princess Margaret had the larger number of procedures performed. And we did note a significant decline during the COVID pandemic between 2020 and 2022, for which our elective cases were postponed or canceled. When we looked at the indications for colonoscopy, less than a quarter of the patients actually had colonoscopy performed for screening purposes. The main indication for patients having colonoscopy was actually PR bleed, 17% of patients. And in another 17, the actual indication was not documented. Females more commonly underwent colonoscopy procedures. And when we look at the distribution by age, patients between the ages 55 to 64 and 65 to 74 years of age underwent colonoscopies more frequently. And we noted increasing in women in the 45 to 54 age group undergoing colonoscopies. The average age of colonoscopy performed was 61 years, which we know is well above the current guideline age for screening colonoscopy. When we look at findings at colonoscopy, over a quarter of patients had normal findings, and 22% actually had pedunculated polyps as the most common lesions. Most of the lesions were less than, in terms of a centimeter in diameter. And looking at the distribution by location, we see that most of the lesions were distributed in the left side, being the sigmoid and rectum, and then another 17% in the right side of the colon. In terms of the histopathologic analysis, over 50% of lesions identified were tubular adenomas. However, 15% of these patients had cancers diagnosed at the time of colonoscopy. When we focus on the patients who were diagnosed with colon cancer, we note that the average age of diagnosis from colonoscopy was 64 years, and we actually had a patient as young as 30 years being diagnosed with colon cancer. The distribution by age is similar to those in terms of who underwent screening, and again, we see women in the 45 to 54 age group having increasing diagnosis of cancer, and that's likely because they've undergone more screening in that age group. The indication for colonoscopy in these cancer patients, again, most commonly was PR bleed in about 30% of patients, and less than a quarter of patients, again, having colonoscopies done for screening purposes. The distribution was similar to that of the general lesions, where we see a higher predominance of actual cancers in the rectum compared to sigmoid, but generally the distribution is the same. And in terms of histopathologic findings, most patients were diagnosed with adenocarcinomas of moderate differentiation. So when we analyze or look at our general findings, we see that most patients underwent colonoscopies mainly for diagnostic purposes, with PR bleed being the main indication. The average age of evaluation was 61 years. And in our study compared to Jamaica and Trinidad, normal colonoscopic findings were found in more than a quarter of the patients, and 15% of patients were actually diagnosed with cancers. Our adenoma detection rate was 12.5 for males and 17.5 for females, and notably females more commonly underwent colonoscopies. However, despite looking in comparison to the publication done in our country several years back, colorectal cancer was diagnosed more commonly in males, despite females being screened more commonly, with a ratio of 1.2 to 1, similar to Chandra et al. And the average age, again, similar to previous study, is 64 years. However, patients younger than 50 accounted for almost 13% of colorectal cancers, and the location is a left-sided predominance compared to our Caribbean counterparts in Trinidad and Barbados, who has a right-sided predominance. The study was limited in terms of our access to documentation. Our CIS was only, in terms of surgeon access, was only developed in 2019, and so we were not able to get information in terms of indications prior to 2019, as well as we were not able to capture the true number of colonoscopies due to limitations in terms of improper coding on ICD coding at the time of booking for these patients. So in conclusions, yes, we are screening too late for colorectal cancer, and there is an urgent need to implement a national screening program with strict adherence to age guidelines within our community. These are my references, and I thank you for your attention.
Thank you so much, Dr. Bodie. Do we have any questions for Dr. Bodie? Okay, I actually have a question. Dr. Bodie, do you think if we would get the same amount of, like in terms of the percentages for patients who were screened who had colonoscopies just for screening purposes compared to those who had symptoms, do you think our numbers would be the same in the private sector? Because I know usually in our hospital, we tend to prioritize those patients who come in with symptoms in terms of screening. Like those patients would present to the clinic for screening purposes, but we prioritize the patients who would have symptoms. So you think we would have a different result if this was done in private patients?
I think we absolutely would find a probably completely opposite results, and private being persons more readily have access to healthcare, mainly because of insurance purposes, or they have the financial means to. And so usually they are screened on time or screened appropriately because they have the access to healthcare. And the persons in public, they usually don't, so they present either way they're symptomatic. But it is something interesting that we can do in terms of a comparison to see what the results actually look like, to get an actual comparative study.
Yes, that would be interesting. Thank you so much for that one, but I see you're up again. So the other presentation that you're going to do for us, the correlation between cancer prevalence and geo-environmental factors in a single community. So this should be interesting as well. Okay. Thank you.
So just confirming again that you can see my slide and not in presenter view.
Not in presenter view, and we can see a slide.
So I would like to start off thanking the SHOs actually in Grand Bahama in the Department of Surgery for assisting with this study, as well as Dr. Chico Colley from Pathology Department and our National Geographic Information Systems for helping me with these results. This, I think, is a very topical, maybe controversial topic, but we will proceed. I have no disclosures. So in 2024, the American Cancer Society released this very, I thought, impactful statement that cancer cases were expected to rise to 35 million worldwide by 2025. And it indeed is a very powerful statement, just speaking to the incidence or the prevalence of cancer within the world. Cancer, we know, is being treated as a chronic disease and poses significant burdens on our healthcare systems, particularly within the Caribbean. The 2020 Globocan reported that approximately 1.5, almost 1.5 million new cancer cases and over 700,000 deaths in Latin America and Caribbean countries. Cancer is the second leading cause of death in the Caribbean, and with failing interventions, the rate is projected to increase by 66% during this decade. In 2007, there was a study performed at the Rand Memorial Hospital by Brathwaite et al., where they completed a retrospective study looking at the pathology catalogs of cancer cases diagnosed during a 15-year period. And that was specific to the Rand Memorial Hospital. They noted a total of 545 new cancer cases with an annual incidence of 167 per 100,000. There were a total of 443 actually diagnosed within the pathology department at the RAND, and of course the majority, or sadly the majority, being female. The most frequent cancers in male were prostate, colon, and lung, and in female were breast, cervical, and colon cancers, with median age of diagnosis of 52 years and the mortality rate of 114.8 per 100,000. And overall survival of 1 year for the general cancer patients. In 2014, the Tribune released a statement by the then Minister of Grand Bahamas, Dr. Michael Darville, who commented that the prevalence of cancer in Grand Bahama raised the question about the environmental effects of the industrial sectors and its impact on residents. And he went on further to state that the government had commissioned a study to be done to investigate same. And I think that may still be done under work. There have been several studies internationally done looking at the effects of the environment, and Robertson et al. Looked at the use of harmful environmental contaminants in cities with increased chemical carcinogens, and in terms of the outcomes, and noted that persons, of course, with living with the higher exposure had more incidence of cancers, particularly those who had more elements in water. Lichtenstein et al. Also looked at the environmental factors compared to inherited genes in terms of diagnosis in patients with cancer, and actually noted that the causation of cancer was actually higher in populations with twins was actually due to the environment and not genetics. Brender et al. Looked at residential proximity to roadways and in traffic-related pollution areas, and noted that there was an increase of childhood leukemias in persons with closer proximity to these areas. And DeRuse et al. Looked at the shortest distance of residential proximity and longest duration, so living closer and living there longer to these affected areas, and noted increased risk in the persons with those factors of developing non-Hodgkin's lymphoma. So although the literature does support a strong association between genetic mutations, and we know we have a high rate of BRCA mutation, particularly in our community, the effect of the geo-environmental factors on cancer prevalence has yet to be investigated. And so we thought to determine the association between cancer prevalence and proximity to industrialized areas in residents of the Grand Bahama Island. Our objectives were to identify all Grand Bahamian residents who were diagnosed with cancer at the Rand Memorial Hospital between January 2010 and December 2024. We also wanted to determine the cancer prevalence rate at the Rand Memorial Hospital, looking at the demographics of these patients, associated risk factors, as well as determining the proximity exposure metric and cluster patterns of patients who were diagnosed. So following ethical approval, a retrospective chart review was conducted and included all Grand Bahamian residents with histopathologic confirmed diagnosis of malignancy during our studied period, and excluded anyone, of course, without a histologic diagnosis or who did not live in Grand Bahama at the time or up to when they were diagnosed. We collected data using SunQuest ICE, as well as had proximity exposure metrics determined with the assistance of Bahamas National Geographic Information System. We created Kaplan-Meier survival curves to determine the 5 and 10-year overall survival of patients in terms of the 5 most common cancers. So those who may not be aware, but this is Erin Brockovich, who was very well known for being an advocate for environmental factors and cancer causation in California. And her story was depicted through the movie Erin Brockovich that starred Julia Roberts. And this is me, and hopefully I won't encounter in terms of the litigations or stresses that she did when investigating the study. So a total of 756 Grand Bahamian residents received a histopathologic confirmation of malignancy or cancer during our study period. We had just over 1,000 tissue specimens. 172 were duplicates, and 135 patients were actually identified as other island patients, and so they were excluded, giving us our total of 756. Most patients diagnosed were female, almost 60%. And when we look at the distribution by age, most were between the ages of 56 and 65 years of age. The most commonly diagnosed cancer was breast, followed by prostate and colon. And when we looked at risk factors, unfortunately, due to our resources in terms of our databases, we weren't able to identify through SunQuest ICE personal history, family history of cancer, persons who had smoking or other genetic factors that may have been contributed to their diagnoses. We were able to determine the incidence and mortality rates for persons who are diagnosed with cancer and noted just over 24,000 cases per 100,000 in terms of the incidence rate, with a mortality rate of 600 per 100,000 persons for Grand Bahamian residents. This slide shows the survival curves for the 5 most common cancers, which were breast, prostate, colon, uterine, and cervical in the order of highest prevalence. And we note that generally most cancers had overall good 5-year survival, upwards of 80%, even 95% for prostate, and still fairly good at 10-year, with the exception of colon that dropped to about 61%. But overall, we had good survival rates at 5 and 10 years for most of our patients. The average age of diagnoses was 53, 61, 61, 57, and 48 years for breast, prostate, colon, uterine, and cervical cancers, respectively. And this graph just shows the distribution by age for the 5 most common cancers diagnosed at the Rand Memorial Hospital. So just to refresh our memories, this is a map of the island of Grand Bahama highlighting each of the constituency areas. Grand Bahama does have 2 industrialized parks. There is one in the western Grand Bahama that is comprised of 13 industrial companies, and one in the east that has only 1. This slide is a very important slide. It shows our total number of cancer cases, and if you look carefully, and I will show a zoomed image, there is a cluster around the western industrial park. And this is a zoomed up image of it showing the cluster pattern specifically around the western park. This next slide shows the similar cluster with the various types of cancer. So you see a variety of colors, just showing the distribution by cancer and by cluster pattern. And again, showing the zoomed image. And that is of the eastern distribution. When we looked at constituency area, generally the incidence based on constituency may seem to be low for each of the various constituency areas. However, when we looked at the absolute risk of developing cancer based on their proximity and based on constituency, we see very high absolute risk and upwards of 27% for persons who live in West Grand Bahama. We also did look at the proximity index, looking at the 1, 2, and 3 mile radius within the industrial areas, and noted a strong negative correlation for a closer proximity index and the development or the diagnosis of cancer for these patients. So the closer they lived, the more cancers we saw in that population. And it was similar for the Eastern Industrial Park as well. So our study did have several limitations. One in that the scope of the study was limited to only the Rand Memorial Hospital. And so, of course, we did not capture the entire Grand Bahama population, as persons may have gone to the Princess Margaret Hospital, gone to the US private places where we don't have access or may not have had access to their actual pathology results. And so we did not have a true representation of the burden of cancer in Grand Bahama. Additionally, we do not have or did not have access to the actual place of employment, as some persons may not live within the proximity or the 3 mile radius, but they may work at those industrial areas, and so they still have daily exposure. Thirdly, as indicated earlier, we don't have access to genetic predisposition, or if they have known gene mutations that may increase their risk for development of cancers, and as well duration of residency. So certain things that probably may require a survey or telephone conference to follow a place of employment or how long they live in those areas to determine their risk. And lastly, looking at other contributing environmental factors such as contaminated water tables, seasonal bushfires, which Grand Bahama is known for. We did not look at those things or have access to those things to determine if that might have caused an increased risk for the development of cancer in these patients. So in conclusion, in comparison to previous study, the prevalence or the distribution of cancer prevalence among Grand Bahamian residents remains relatively unchanged. The most commonly diagnosed cancers at the Rand Memorial Hospital were breast, prostate, colorectal, uterine, and cervical cancers, with the average age of diagnosis for patients presenting being 57 years of age. The absolute risk of developing cancers was highest in the persons who live in West Grand Bahama, and the strong negative correlation between cancer prevalence and closer proximity to industrial sectors implicates its role in causation of cancer in Grand Bahama. These are my references, and again, I would like to thank you for your attention.
Thank you, Dr. Bodie. That was a very interesting research. Very, very good. Thank you. Any questions for Dr. Bodie? Okay, Dr. Bodie, you said you were interested, or are you interested in going a bit further with this research in terms of maybe possibly getting notes from the RAN for those patients that are in ICE to determine, place of employment? Just ask a little bit more questions, or you think that would be something that would be helpful?
Right, so those points that were listed in the limitations were things that we want to investigate. Is just that the notes factor is going to be an issue because after Dorian, everything was wiped out. So it would have to be more of, I guess, survey of persons who we have, I guess, identified or recognized in the study population.
Mhm.
So that again would be a different ethical process to get permission to interview these persons, see how long they lived there, where they worked, to get those things. But yes, those are other things that we would like to look into for further study.
I think, okay, so I think Dr. Marcus Cooper has a question. He said she mentioned negative correlation. Sorry, Dr. Cooper? In the last slide. I couldn't see a question. You want to speak up?
Yeah, I think I saw what he said, but the correlation index, it was a negative index. So even though there was a shorter distance, there were more persons who were identified, hence being the negative correlation.
Any other questions for Dr. Bodie? Okay, that was a very, very interesting study, Dr. Bodie. Thank you very much. As someone who lives in Grand Bahama and who sees the actual results of this, all the patients coming into the hospital with cancers. So I understand exactly what's going on here. And if we could get more information about this, that would be good. But thank you so much. It was a really good presentation. Okay.
Thank you too.
And so we're moving on now to our next set of presenters. We have a duo, Dr. Lyons and Dr. Ongera, and they're going to talk to us about colonoscopy outcomes following positive FIT, fecal immunochemical test, and the fecal occult blood testing. This is a retrospective study. It's done at the Princess Margaret Hospital from 2023 to 2025. I'm sure this is going to be very interesting. I'll let you know a little bit more about the presenters. Dr. Lyons, Crystal Lyons, she's completed a primary and secondary education at Queens College in Nassau. She earned a Bachelor of Science at the University of Richmond. She graduated with a Bachelor of Medicine and Bachelor of Surgery from the University of the West Indies. She's currently pursuing a master's in clinical dermatology at King's College London. Her journey through these institutions has nurtured a deep love for learning and sparked a keen interest in research. She is grateful for the opportunity to present at this forum and engage with fellow researchers and clinicians. Okay, then we will give a little bit of info about Dr. Ongera. She's a medical doctor with expertise in clinical practice across different healthcare settings. She trained in Kenya, where she was particularly passionate about improving health outcomes in underprivileged communities, and later practiced in the Bahamas, gaining valuable experience caring for diverse patient populations. She's now based in the United States, but she's pursuing opportunities in research with a particular interest in non-communicable diseases. Her medical journey across different regions has equipped her with a unique perspective on the challenges and opportunities in modern healthcare systems. Let's welcome both Dr. Lyons and Ongaro.
Thank you, Dr. Stubbs, and good afternoon, everyone. So today we've chosen a blue theme for this presentation, as blue is the color of Colorectal Cancer Awareness Month, which is normally observed every March. But wouldn't it be wonderful if we didn't need a blue March, because prevention and early detection had made colorectal cancer rare? So to take a step towards that goal, Doctors Cooper, Onyeda, and I examined colonoscopy outcomes after positive fecal immunochemical test and guaiac-based fecal occult blood test. And by studying our own population, we take another step towards making the Bahamas healthy again. We have no financial disclosures and no conflicts of interest. We'll be discussing the contents of our manuscript from introduction to references. So let's begin. Colorectal cancer is the third most common cancer, not only across the globe, but in the Bahamas. And according to GlobalCan 2022, colorectal cancer was the second most common cancer among males and the fourth among females in the Bahamas. However, it remains third among both sexes after prostate and breast cancers.
These findings underscore the importance of colorectal cancer screening, as it is essential for early detection. For average risk individuals, current guidelines recommend initiating screening at age 45. Among the screening modalities, colonoscopy remains the gold standard as it allows for direct visualization. However, stool-based tests continue to be an important component of screening strategies. In our setting, the NHI patients currently utilize the fecal immunochemical test as the primary screening tool, while the Department of Public Health employs the guaiac-based fecal occult blood test. Let's take a look at the key differences between the guaiac-based fecal occult blood test and the FIT test. First, the GFOBT is a chemical assay and detects the heme component of red blood cells, while FIT is an immunochemical assay that specifically detects human globin. GFOBT requires 3 consecutive stool samples, while FIT only needs 1 sample, and this makes FIT more convenient for patients. In terms of accuracy, GFOBT may yield a false positive result in patients with upper GI bleeding, whereas FIT is not affected since globin is degraded before reaching the lower bowel. In terms of restrictions, patients using the GFOBT must avoid red meat, NSAIDs, high doses of vitamin C before testing. FIT, on the other hand, has no dietary or medication restrictions. For both, the test should be avoided when there is menstruation or active hemorrhoidal bleeding, as this may interfere with the test results. Finally, the GFOBT is simply considered an older method, whereas FIT is new and the preferred method in most clinical settings because of its higher sensitivity, specificity, and ease of use. So some of the challenges we face in colorectal cancer screening is the inconsistent pre-test instructions for the GFOBT test by clinicians, and also just concerning patient compliance. And also on the FIT, there are non-standard qualitative FIT assays that are used, and this causes variable results and raises concerns of test reliability. And all this simply leads to unnecessary colonoscopy referrals, leading to a strain in the limited endoscopic resources that we have.
So in response to these challenges, the present study aims to evaluate colonoscopy outcomes among patients with positive stool-based tests. And in doing so, it can compare the superiority of one stool-based test over the other in the detection of clinically significant lesions like colon polyps and masses. So this study included patients who were referred to the specialty gastroenterology clinic for a positive GFOBT or qualitative FIT, and subsequently underwent a colonoscopy at the Princess Margaret Hospital in Nassau, Bahamas between 2023 and 2025. All colonoscopies were performed by consultant gastroenterologists. The study group's demographic data and endoscopic findings were retrospectively collected from both the theater list and operative reports, respectively. Then data analysis was performed using statistical product for social solutions.
So moving on to results, our study included a total of 75 patients who met the eligibility criteria. The mean age of the participants was 65 years, and there was a female predominance representing 61.3% of the study population. 3 colonoscopies were aborted due to incomplete bowel preparation. So 52, which was about 69%, and 23, which is 31% of the patients had a positive GFOBT and a FIT respectively. So looking at our table, this simply summarizes the colonoscopy findings. We particularly wanted to highlight the 2 important findings, which are colon polyps and masses. And among the patients who underwent FIT, 12 had polyps, while 18 patients in the GFOBT group had polyps. In addition, 2 colon masses were detected in each group as shown in the table. So when we compared the diagnostic performance, the positive predictive value was 38.8% for the GFOBT group and 60.9% for FIT.
Based on these positive predictive values, FIT was better at detecting clinically significant lesions. This not only reinforces FIT's value in colorectal cancer screening programs, but also underscores the need to perhaps replace GFOBT with FIT. There were also more than twice as many referrals following a positive GFOBT as compared to FIT. And this is likely because the public clinics still rely on GFOBT and usually have more patients to care for. However, these referrals yielded fewer true positives, indicating that GFOBT is perhaps a less reliable test and a less efficient use of healthcare resources. And lastly, most participants in our cohort were female and elderly. This raises the question, are we missing premalignant or malignant lesions in males and middle-aged adults who are not screened? And does lack of screening play a role in colorectal cancer being the second most common cancer in males in the Bahamas? While these findings provide important insights into colonoscopy outcomes following positive stool-based tests, several limitations must be acknowledged. First, the small sample size limited the generalizability and statistical strength of the findings. Second, it was not possible to verify whether patients received or even adhered to instructions regarding restrictions, which is particularly relevant to GFOBT performance. And third, to our knowledge, digital rectal examination was not used to obtain stool samples. And that's important because its use could have impacted sample adequacy and test accuracy. So in conclusion, in resource-limited settings like ours, colorectal cancer screening programs must prioritize tests with the highest diagnostic yield. And this is to ensure that the efficient allocation of scarce endoscopy services is adhered to. The colorectal cancer screening program in the Bahamas could perhaps be improved if standardized and quantitative FITs were offered by the NHIA and DPH. And educational initiatives need to be directed toward men and even middle-aged adults to ensure that premalignant and malignant conditions are not missed. We've listed our references here and here, and we would like to thank the UWI SCMR Research Days Conference for the opportunity to present. We would also like to thank the GI department at PMH. That's Drs. E. Cooper, B. Moxie, and G. Roll. Special thanks to Dr. Cooper, who spearheaded this study. And finally, we'll leave you with this to digest. Thank you.
Thank you so much, doctors, for your presentation and your study. It was really great. Thank you. I'm looking in the group chat to see if we have any questions for you guys. Just wait a minute to see if anyone, responds. Okay. Looks like we don't have any questions for you. Oh, Dr. Sinkley, yes, we have a question from Dr. Sinkley.
Thank you very much. Thank you for this study and the presentation. Just wondered, what is the cost for the test, the fit? And then, any screening tool needs to be at least something that is affordable. I see the results that suggest that the fit is superior to the fecal occult blood testing, but I just wondered what the cost is for it.
I don't have an exact cost with me, but I know that the fit is typically a little more expensive than the GFOBT, but that's in the short term, because in the long term, the fit would hopefully be able to, oh, I see someone wrote in the chat, fit can cost about $30 to $35. The hope is that if fits are used throughout the hospital system and the public clinics, it would be better able to pick up on certain premalignant and malignant conditions, and then we can hopefully have fewer colonoscopies that never needed to be performed in the first place.
Agreed. So I think that in your write-up, you might want to emphasize this same point that you just delivered, to talk about cost and that it would be feasible in the long run to use this as the screening tool. Thank you very much.
Thank you, Dr. Sinkley.
And I see one of our doctors mentioned in the group chat that the fecal occult blood tends to be more labor intensive, because you need 3 samples. And I could attest to that, because a lot of the patients don't come back for the second or the third.
Mm-hmm.
They don't
Yes,
come.
ma'am.
Yeah.
Patients don't even want to do the first test. So
Exactly. Exactly. They don't. But thank you again. I don't see any more questions, or thank you again for an excellent study. Okay. So we're going to take a 5-minute break, just a 5-minute break. Before we do, I want to just give a shout out to our sponsors. Our sponsors are Celca Lab Clinical. We also have Consultant Physician Staff Association, Doctors Hospital, Medical Association of the Bahamas, Medical Protection Society, Nestle, National Insurance Board, Public Hospitals Authority, Spotted Doc, Springer Nature, the Ministry of Health and Wellness, and individuals such as Dr. Pinda Butler and Dr. Wells. Thank you so much, guys, for your contributions. I also want to remind you that you have to complete the feedback form to obtain CMEs, and it will be like $100 to claim. We would share the QR code on the screen for the CMEs after the sessions, okay? So we'll take a 5-minute break, and then we'll be right back.
Welcome to another Nestle Education Segment Bite for healthcare professionals only. The World Health Organization recommends exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. In our quest to provide the best, we have gone a step further, studying breast milk to understand what it delivers for growth and development. This study has birthed our newest option, NAN, with optimized protein, probiotics, and human milk oligosaccharides, while maintaining the proven macro and micronutrients we combined before. As we balance the ingredients of our exclusive combination for reconstitution by your little patients, we ensure even more of the solid components are represented in our infant formula, now including HMOs, specifically 2FL, found in 80% of breast milk worldwide and account for 30% of the HMO component. Coupled with the right amount of protein for structural cell and tissue formation, essential neurons and hormones, and general overall body functions, NAN has all that an infant formula currently needs. Even the probiotic blend is superior among infant formulas on the market with our specific selection for the growing infant. Choose NAN with your patients unable to breastfeed for this exclusive combination today. For any further questions, please reach out to a Nestle representative via telephone or WhatsApp. Do enjoy.
welcome back, everyone. Once again, I want to say thank you to all the presenters for their insightful work and contributions to advancing cancer care, screening, effectiveness, and public health understanding, right? So that we conclude the research portion of our cancer research and screening session. So we will now move on into the special segment is presented in collaboration with Springer Nature. And this segment is designed to support researchers in strengthening their scientific communication and publication success. Our topics include how to write for publication and journal publishing, helping researchers navigate the publishing process. And our keynote speakers will be Dr. Faith Sue and Brittany Holland. Faith Sue is the statistics publishing editor for Springer in the Americas. She has a diverse background in education publishing, ranging from children to professional books. She publishes statistics books within wide-ranging topics, including biostatistics, education, measurement, and sports. Brittany Holland is Associate Publisher of Mathematics Journals at Springer Nature and has been working in the mathematics publishing field for over 10 years. She is passionate about collaborating with the research community and improving the publishing journey. So let's welcome both of them now.
Hello?
Yes, hi.
Hello, hi Faith, hi everyone.
Hi. Hi. So Brittany and I talked and I volunteered to go first. So I realized that my title was misleading. I'm not going to talk about how to write, but I'm going to explain the publication process, and hopefully it will be less intimidating for you to consider writing a book. Let's see. I'm so sorry. I'm just getting used to the Zoom because this is not, but do I share? Let's see, share.
Yes, you can share your screen. There we go.
Okay. Sorry, this is the best I can do. For some strange reason, it's not letting me read my other screens. Okay, so sorry about that. So what I meant to say, the title is not, I'm not going to talk about how to write a book. I'm going to talk about the publishing process so that it won't be as intimidating. So I'm sorry about that, but I just want to introduce myself. My name is Faith. My name is Faith Sa. I work in the New York office of Springer Publishing. We are a global company, but we have offices in the US, Europe, and Asia. And I work in the New York office. Here are some of our class titles. I hope that you are familiar with some of these titles. And these are some of our bestsellers on our list. And I know that these are all yellow, and that's marketing purpose. It's so that people can say, hey, that's a Springer book. And so that's why when you see our books, they're all yellow. These are the type of books that we publish, and I just wanted to explain why they are categorized differently, because it's for marketing purposes. When you approach us and say, oh, I have an idea and I think I want to write a textbook or proceedings or whatnot, then it helps us market your book and do, better in the marketing. So I just wanted to go down and explain what all of these are. I'm sure you're very familiar because you use them either professionally or academically. Contributed volumes are just what it says. An editor, decides, hey, I have a lot of colleagues or peers that focus on a particular topic in biostatistics or, business or whatever. And so the person decides, oh, I'm going to write a book and, get all this information together. And so it's a big endeavor, organizing and, 14 different authors and then, who gonna write a chapter and contribute it to a book. And then the editor has to edit it and make sure that it's consistent. It's the topic is, relevant. And then, and also as well as working with Springer to get the book published. So that's what a contributed volume is. A lecture note is someone who has a lot of notes, who taught a lot of classes, who went to a lot of conferences and sessions, and they have a lot of these notes just on their computer, and they said, hey, I should publish these into a book and on a particular topic, whether it's, on R or epidemiology or something. They just have a lot of series of pages that they want to organize and introduce as a book. Monographs are basically research or methodologies, best case, someone who wants to write a book about their experiences and best usage, and they just want to present their experience. So that's usually a monograph. MRW stands for major reference work. These are those big blue books that you see from Springer. They're like over 1,000 pages. And again, this is someone who decided, I want to talk about biostatistics and all of the methodologies and the data and all of that and how they do it. So then again, they organize through their colleagues or peers and they gather them and then they all contribute a chapter to the reference book. And these are obviously, very timeless and they're very relevant. Proceedings are chapters or abstracts, papers that are presented at conferences. So, a lot of conferences throughout the year, if they decide they want to organize their sessions into a book format, then it would be a proceeding and then they can get it published. Someone would have to edit again and organize all of these different chapters. Professional books are people who are in the sectors and they have a lot of experience and knowledge and they want to talk about what they've learned and how to, best practices again. And these are for professionals, people in the field rather than academics. But we have found talking to a lot of our customers that professionals will read a textbook because they want to refresh a course. There's a lot of new software and they want to read and learn how to use it. So they'll pick up a textbook. And we've learned that professional books are used in classes so that they can prepare the students to go into practice in the private sector. So even though authors come to us and they have an idea and they want to write a book in a particular style, we don't know how it's used until someone picks it up. Springer briefs. So Springer briefs are usually less than 125 pages. These are very short books and they're actually published quicker too. Sometimes if somebody has written a lot of articles and they want to organize these articles into a book format, that's welcome, but you cannot like copy and paste. You can't just republish an article that was already published for citation purposes, obviously, but also self-plagiarism. So what they'll do is they'll take some of their articles, and then they'll organize them, they'll rewrite some of the examples, some of the case studies, whatnots, and then present it in a book format. And these are usually, quicker too. This is a smaller book, obviously, so it's quicker in production and quicker in writing too. So a lot of the authors find it more convenient when they already have a lot of materials written out. They just need to edit and organize it into a book format. Textbooks obviously are textbooks. These include exercises. They also include supplemental materials or solutions, and they're obviously catered to the class. Trade books. So trade books are for lay people. These are not statisticians. They're not anyone who has a specific knowledge in statistics, but they're interested in statistics. They're interested in like data or whatever. And so if somebody who loves to write, and these are very casual, there's no equations, nothing technical. These are just for people who are interested in learning about what statistics is and what is data and whatnot. So, people who enjoy writing and would like to teach about statistics, but in a more casual way, that would probably be a trade book. So let me explain to you what happens. Again, this is just to encourage you rather than discourage you into writing a book and, not be intimidated by like, Gareth James or, any other books that are already published. I feel like you have a unique experience in your field. You have experience, you have a unique knowledge. And so if you are interested in taking the time to write, then I would encourage you to think about sitting down and, organizing a book in a organized manner, in a format, and we would be very interested in looking at it. When you email me, and here's my email. When you email me and you say, oh, I'm interested in writing a book, I can send you a proposal form. It'll ask you to describe your project. And it asks for what is your unique about your books. And this is usually for marketing after the book publishes. We would require 2 to 3 sample chapters and then your latest CV. We peer review your chapters, and all our books are peer reviewed. And if it's positive, we offer you a contract. And if it's negative, the reviewers often tell us why, and they give us feedback on, how to improve the chapters and what's lacking. And if you are, not intimidated by it all, you can reformat and rewrite and, do what you can and resubmit it. And we would still be very interested in seeing the updated chapters. So after we offer you a contract, you tell us like, I'm teaching a lot of classes, I'm really busy at work, I have personal life, all that. And you say maybe 2027, 28 is when I'm finished with the book. So you really set the time schedule as far as when the book can be written and when it will be finished. Once you finish the book, you submit the manuscript file to us. We give it to our production team. They review for errors, typos, grammars, any errors in the figure or tables, and then they lay it out in page format. We give the proofs to you for review. You check for any errors, and we work to make sure that it's perfect. Once you approve the proofs, then we're going to publish publication. The book becomes available in our library collection, on our booksellers. We work with Amazon, Barnes & Noble, other textbook or online booksellers. And we work with our sales team. We have library teams. So we basically do our best to market your book. If the author is, going to a conference or anything, we support them with flyers, discount codes, whatever they need. So, we do want to be, even after the book is published, we want to make it available to be supportive of, making sure your book does well and that the word is spread that your book, has a lot of information. And honestly, we are a publisher book, but we also are, we feel like at Springer, we're research partners. We're research providers for a lot of people in science. And so we want to make sure that all of this, information is being shared, whether through, journals or books. And, don't be intimidated by the idea of writing an entire book. But I would encourage you that you have a lot of materials already. You've written a lot. And so if you want to take the time and to just organize it and, think of like, how can I present all of these notes? I would be very interested in being in contact with you. So please don't, if you have any questions, you can email me and I'd be happy to answer any questions. We're always looking for people who have a lot of information that they just want to share. That's it.
Okay, so we'll wait for Ms. Holland.
All right. Hello, everyone. Thank you, Faith. I'll go ahead and share my screen now. All right. Can you see my screen? We're good?
Yes.
All right. So thank you for the invitation to present today. My name is Brittany Holland. I'm an associate publisher with Springer in the Journals Group, based out of our Philadelphia office. So today I will be going over how to help researchers navigate the publication process. This is for Springer, but this is in general for any publisher. So getting published. Some tips to make it happen. Your manuscript's more likely to be accepted if it is within the scope of the journal, describes research that advances the field, adds to an active research field, is carefully prepared and follows the journal's submission guidelines, uses clear and concise language, and follows ethical standards. So I'll be getting into a little bit of everything more over these next few slides here. So starting with your title, it's very important. That's the first thing your reader's going to see. So you want to grab your reader's attention. So definitely important to include what's important, keywords for indexing purposes, and to be concise. You definitely want to keep your title less than 15 words. You definitely want to avoid including any questions, being vague, or any abbreviations. And then the most important question when you're preparing your research, who is your target audience? Who is going to read this manuscript, and who do you want to really reach out to? So think of things like, where are these findings relevant? If it's local, you could find a regional journal. If it's more worldwide, you can find an international journal. And then who is this relevant to? If it's just within your specialized field, a specialized journal is usually best. If it's your field as well as others, an interdisciplinary journal is your best bet. And then, of course, is accessibility important? You can choose open access to allow more accessibility to industry policymakers, outside of academia or industry. So Springer has a journal finder. I believe these slides will be shared, so there's links throughout to help you for Springer's page. But the journal finder, you'll see there's a search box. You can put a title and abstract keywords. You can also browse by subject, as you'll see on the bottom right. So this can be very beneficial in helping you narrow down which journal for Springer you would be best to submit to. Like it says, you can browse thousands of peer-reviewed journals across all fields, look at open access options, and we also have many tools for our authors. Once you select your journal, so I have an example here, this is COAM. Like I mentioned in the beginning, always look at the journal scope very carefully before submitting. You want to make sure your journal is within that scope, because one of the top reasons for quick desk rejects is papers out of scope of the journal. And this is what all of our web pages look like for our journals. So you'll see the about this journal, and then there will be an option for aims and scopes. You also definitely want to check the journal guidelines before you submit to make sure you adhere to all of what's needed to submit your paper. And then use recent journal content to frame your cover letter and show originality. We also provide free researcher support on the Springer webpage. I know this is small text and a lot of information, but like I said, I'll make sure this slide deck's passed around, but we have a lot of tools electronically to help you gather your work and see the best place to post it, to submit to. A lot of tutorials, I should say. And thinking about submitting your work, a lot of people always think impact factor. It doesn't have to be just about the impact factor either. Other bibliometrics matter, and the impact factor can vary greatly over a journal's lifespan. It's always important to dig deeper and find out what percentages of papers actually get cited at all. The number of downloads and accesses is often a much better indicator of the impact of your research. So do your own research of these metrics before submitting your work. We'll do a little bit on open access here. It is the foundation of our support of open science. Of course, it's got many benefits for researchers, institutions, and beyond. It increases downloads, increases citations, enables reproducibility, and improves and enables interdisciplinary research. Outside of academia, it supports real-world applications. It makes publicly funded work more accessible, makes it easier for researchers to access, understand, and build on the work of their colleagues. So one thing, if you have more information available about open access, about our transformative agreements at this link on the top right. But our transformative agreements cover journal subscriptions and open access publishing fees. So if your institution that you work at has one of these transformative agreements, open access fees in our Springer journals are fully covered. So it's always good to take a look at your institution, talk to your library, see if you are part of one of these agreements, because it's very beneficial to you as a researcher and to the research community. Of course, open access articles do receive more attention than non-OA. And these agreements, the transformative agreements, also help authors comply with funding mandates. So this is just a list of a bunch of all the countries. This might not even be all of them that we have transformative agreements with. So we have agreements with institutions as well as countries. So again, I put that link up there to take a look when you want to find more information about if you are covered under one of these agreements. Then we'll just do a little bit about peer review. Peer review is a positive process. Experts give you advice to help you improve your manuscript. Everyone wants to see their colleagues doing their best. So I just put this little in here, the cartoon, just as fun here. And peer review, it advances the work. So if I know there can be issues with peer review. People are sometimes a little reluctant, but with Springer, you can get involved yourself. So we welcome researchers to follow our online tutorials. There's also a link to become a peer reviewer. So you can look for mentorship opportunities if it's your first time of how to better peer review. Like I said, we offer tutorials, and it only benefits yourself and your colleagues and the community if you're contributing as a reviewer and offering constructive scholarly work to your colleagues. Finally, we're going to talk about when you get your decision. So if you receive a revision decision and how to respond. Make sure you're clearly discussing all the points that were mentioned in this revision. So state what was revised. Always refer to page and line numbers to make it easier for your editors, for your reviewers. And in the manuscript, if you can highlight the revised work. The cleaner and easier it is for your editors and your reviewer to find this information, the happier they'll be and moving on with a decision on your paper. If you are rejected, what happens? Let us help. So Springer offers a transfer desk. So what this means, so if your paper is desk rejected, say it's out of scope, we have our transfer desk service that will look at your paper and offer one-on-one consultation to submit it to a journal more in scope or more fitting. They'll help find a best home for your journal. So don't be immediately defeated if your paper is rejected. There are tons of journals that it could fit better in, maybe a more niche journal, maybe just a journal you hadn't thought about or didn't know existed. So we do have this service. Again, you can find more information on the links provided. If you're accepted, celebrate. It's exciting. That's good news. We all want to be accepted. And we definitely encourage everyone to promote your work when it is accepted and published. You can do this at conferences, via social media, all kinds of media. Publisher promotion, we're happy to help you promote your work as well. With that, Springer offers a service called Shared It. This allows anyone to read your article, free access. You can share it anywhere. Again, I put the link on the bottom right. This is just an example here, but you, as the author of the paper, you can copy a link, share it to whomever you'd like, and they will be able to read the full text article free of charge. So that is a good service that you should definitely take advantage of if your paper is accepted and posted. So that is all I have for you today. I know it's a lot of information in a short amount of time. My contact information is here, and I provided a bunch of links, and always happy to answer any questions. And again, thank you so much for the opportunity to present today.
And thank you very much. It was very informative. Okay. I'll ask our panel or our group chat. Do we have any questions for Springer contributors?
One question. As it relates to the transfer desk
Yes, they'll reach out to you
service.
after. Yes. So thank you so much for those practical, insightful guidelines or tips. We really appreciate it. And to all of today's speakers for their expertise, passion, and dedication. We hope that this session has inspired deeper inquiry, collaboration, and continued impact in cancer research and scientific publishing. Thank you to the audience for your engagement. We're going to now conclude this session, but we are also going to remember our sponsors again. We're going to put up our sponsors who helped us to organize or in organizing this great event. And thank you very much. And that ends our session.